Hello, my name is Yanko Limon. I'm a grad student working on my master's in nursing education, and I'll be giving the presentation on end of life and palliative care. A little background history on me. I've been a nurse now for about 14 years, have extensive med-surg experience, particularly in kidney transplant, liver transplant, and pancreas transplants. Also have experience in ER nursing, trauma ER nursing at Banner, Maine. Also, at the moment, I'm a research nurse. I work at the Cancer Center at the University of Arizona Cancer Center, working mostly on clinical trials, cancer research. Anyhow, moving along, let's get on this end-of-life palliative care discussion. Here you have the learning outcomes. I will not read them to you. I will go ahead and let you read them at your own pace. 9 outcomes. They're pretty much pulled from your D2L. All right, palliative care. Before we talk about what it is, your textbook did mention the fact that we as humans are living longer lives. 50 years ago, we didn't live beyond maybe 50, 60 was the life expectancy. Now it's like what, 70? Some people live into their 80s, 90s. That's becoming more common. With that, unfortunately, comes diseases that are essentially diseases of aging, and when people get older, there are more common diseases. So this leads to pain and suffering due to chronic diseases that are related to aging. So palliative care, what is it? It's a specialized form of care. The focus is to relieve pain, symptoms, and stresses associated with severe illnesses and progressive diseases. The main point here is to reduce suffering. We want to increase quality of life, not necessarily quantity. Can exist concurrently with curative treatment. All right. In this slide, we have some examples of type of palliative care patients. We have dialysis patients, any patient who's on artificial ventilation. We have chronic progressive diseases, patients who suffer from like those kind of diseases like cancer, cirrhosis, and end-stage renal disease and Alzheimer's. As I mentioned earlier, we have a very aging, we are living longer. The population is aging, and unfortunately, Alzheimer's disease is going to be very prevalent. So yeah, we're going to have to, those are some of the examples of patients that would fall under palliative care. All right, hospice care. What is hospice care? Hospice care does fall under the umbrella of palliative care. The focus of hospice care is on terminal illness. Is the patient dying? That's what it's primarily meant to take care of, is a dying patient. Usually, it's less than 6 months to live. There's got to be the life expectancy / prognosis of this dying patient. So yeah, hospice care. Main focus is a dying patient. I decided to include this graph from your textbook, Integrated Palliative Care Model. I think it's a wonderful graph. It pretty much illustrates in a graph what palliative care is, hospice care. So there it is for your reference. Here's another table that I pulled from your textbook that I think it's a very informative resource, hospice care FAQs. The one major FAQ that I think is important is who can receive hospice. Remember, it can be any patient that has a prognosis of 6 months or less of life expectancy, and who decided to no longer pursue any curative treatment. The exception to that would be a pediatric patient. Per the Affordable Care Act, a pediatric patient is not required to forego any kind of curative treatment. The other question that I've had patients ask regarding hospice care is who's going to pay for it? A lot of times it's Medicare, medical systems. A lot of insurances provide hospice coverage. So they're not going to, be expected, hopefully, to, pay out of pocket for hospice care. So yeah, that's a quick reference. I think it's very informative for you all to utilize. The wonderful thing about palliative care, hospice care, is that it doesn't necessarily have to be in a hospital, or it doesn't have to be in like a nursing home or nursing facility. It can be in your home, for example, in the patient's home. So yeah, it can take place in a hospital, outpatient clinic, infusion centers, community rehabilitation centers, nursing facility, at the patient's home, or even a dedicated hospice facility. So there's broad areas where palliative care, hospice care can take place. All right, now we're going to talk about the domains of palliative care. Domain number 1 is about the structure and process of care. Keep in mind that for most patients, palliative and hospice care is a brand new topic to them, so they're going to require a lot of education. So as a hospice provider and RN, you got to make sure to have a care plan ready for them, and not only have it ready for them, but to explain it to them and educate them as much as possible. You got to make sure to incorporate the patient's goals, and those goals should be flexible. You got to make sure to incorporate any preferences, any values that the patient may have. And you got to make sure not to educate the patient, but obviously the family about palliative care and the whole hospice process. Another thing to keep in mind is to not to be afraid to essentially reintroduce the topic of death, especially as the prognosis of the patient's disease process may deteriorate. All right, domain number 2 is talked about the physical aspects of care. This essentially incorporates the nursing process. The focus is symptom management, and essentially you got to make sure to keep your patient comfortable as much as possible. This entails you essentially assessing your patient. You need to treat your patient, document signs and symptoms, for example, pain, dyspnea, constipation, nausea. And of course, once you do an intervention, you got to make sure to assess if the interventions were effective. You got to document the interventions if they are effective. Also, based on how your patient is doing, you got to make sure to touch base with the provider and the interprofessional colleagues to communicate if the effectiveness of the interventions, and adjust accordingly if needed. Domain number 3 deals with the mental well-being of the dying patient. Do you notice your patient's anxiety? Do you notice if they're getting, depression, delirium? These are the type of questions you need to ask yourself and you need to assess for. Obviously, you need to use the appropriate scales when you assess your patient for depression, delirium, anxiety. And of course, if they are suffering from these psychological, psychiatric signs and symptoms, you got to make sure to manage them sooner than later. It's not only about the patient, you got to make sure to keep the patient's family in mind in regard to emotional, psychological reactions in regard to the end of life process. And you got to make sure to provide them with the appropriate coping tools and resources. Ultimately, like I said, you're caring for the patient, but not only the patient, but also for their loved ones and their family. Domain number 4 is in regard to helping the patient navigate the social aspects of care, any advanced care planning. This should bring to mind, for example, like advanced directives. In helping the patient with this and their family, we got to make sure to assess the patient and the family's social networks, cultural concerns, legal concerns such as making a will, any financial concerns, financial resources, caregiver availability, coping skills, access to meds, medical equipment. In regard to advanced care planning, we got to make sure to incorporate the patient and their caregivers and the whole decision making about future healthcare plans, like power of attorney, for example. The patient and the caregiver will need help navigating such things as advanced directives, and end of life wishes. We got to make sure to document that and make sure that those documents are easily available, accessible, in their term, for example. The other thing that's very important is we need to make sure to ensure comprehension about the disease process. A lot of times, sometimes there may be a disconnect or miscommunication. The patient, we think the patient understands things, but we later find out that they don't. So we got to make sure to always confirm, like, hey, do you understand, what's going on? And a lot of education involved here. We also got to make sure to clarify expectations regarding treatment. It's like, hey, this treatment it's not necessarily curative. It's just palliative. It's meant to make sure that you're not in pain or suffering. We got to make sure to determine therapeutic goals and wishes. Domain number 5 is about spiritual, religious, and existential aspects of care. This is a very important domain. Make sure as an RN, healthcare provider, do not undermine it. We got to make sure to respect your patient's religious or spiritual care. So yeah, the main point here is to, don't disregard this. If you feel your patient needs spiritual guidance, care, etc., we need to address that. A lot of hospitals, most hospitals should have a chaplain, and those chaplains are a good resource to help facilitate any kind of spiritual care. They may even help to reach out to the patient's church, for example, for their priest to come in, etc., etc. So yeah, domain number 5 is don't disregard this. This is I've learned in my experience in 14 years that we got to make sure to address this and like, hey, make sure your patient's taken care of. And the family members as well in this regard. Domain number 5 somewhat segues into domain number 6, cultural competency and aspects of care. This is a big deal because obviously we live in a multicultural society. We need to make sure to be culturally sensitive, culturally competent, and culturally respectful. We got to respect other people's culture. We can't just impose our cultural ways on our patients. This entails obviously making sure to address how healthcare decisions are made in that culture, family, point of contact, who's the family point of contact. Make sure to address diet preferences, culture ideologies on death, suffering, and grieving. I know in most American U.S. culture, death is taboo. It's something that it's not discussed. It's something that's like, oh my god, it shouldn't happen. Whereas in some other cultures, they may see it as like, hey, it's part of life, and they make fun of death. Not necessarily embrace it, but just be like, hey, it's something that's gonna happen. I know in Hispanic tradition and culture, they sometimes pray to la muerte, death. It's kind of like, hey, like. So yeah, there's different cultural aspects, and we got to make sure to respect those. Funeral, burial preferences, you got to address that. So yeah, make sure to always respect and be culturally competent. Domain number 7 is regarding care of the patient when death is imminent. I pulled this table from your book as well. The dying process, I think, is pretty darn descriptive. Stage 1, 2, and 3, early stages, acceptance that death is approaching. I've personally witnessed this in a patient. However, I didn't realize that this was going on until the patient passed, and I was like, oh, this is what was going on. But yeah, the patient may begin to withdraw, loss of interest in social contacts, loss of appetite, decreased needs. Yeah, they weren't eating; they just didn't have hunger. They were not drinking water. They were sleeping more. Stage 2, the middle stages, decline in mental status, confused, disoriented. Yeah, these are some of the things that I was witnessing in one of my cancer patients, and I kind of knew it was happening, but in hindsight, it was like, oh yeah, that was the dying process. He was just ready to let go. But yeah, this is straight from your textbook. It's a table, pretty darn good description of the dying process. Continuing on the domain number 7, the dying process, nursing care priorities and goals for near end of life. The big deal here is symptom management. We don't want your patient to be suffering. We don't want them to be in pain. Morphine is a good pharmacological treatment for pain, obviously. In regards to the principle of double effect, so there's the whole discussion about ethical pain management versus hastening death. We as nurses are, when we're giving morphine for pain relief, we are ethically protected, I guess, from the principle of double effect. It's like, yeah, you may be hastening death, but you're also not you're making sure that they're not in pain. Non-pharmacological treatments for pain, you have acupressure, essential oils, fans. Make note if your patient is not verbal to watch out for those nonverbal cues that they're in pain. Respiratory distress. A lot of times as they're dying, yeah, they sound like they're in respiratory distress. They're starting to, their breathing is different. They have dyspnea, tachypnea, upper airway gurgles. You got to treat that with anticholinergics, bed position, opiates, delirium. Yeah, as they start to get to delirious as they start to die. Treat with reassurance, familiar sites. You have pharmacological treatments, Haldol, benzodiazepines in worst case scenarios. Make sure to address any causes of delirium. For example, some meds can cause delirium, constipation, maybe they have a food bladder. All right. Domain number 7 continued, nursing care priorities and goals for near end of life. Family support, a big deal. We got to make sure to incorporate the family as much as possible. Don't be the only one, offering patient comfort. You got to make sure to, facilitate the family providing that patient comfort, including bathing, massaging, reading to the patient. Make sure to, maintain that communication with the family, let them know what's going on. Be there for them. Practice reflective listening, empathy is paramount. You got to make sure to empathize with the family as much as possible. And don't forget to prioritize patient family preferences. Domain number 7 continued, nursing care priorities and goals for near end of life. I pulled this table from your textbook as well. I think it's very, very informative. Care of the family. I'll go ahead and let you read that at your own leisure, but this pretty much hits the nail pretty good. Domain number 7 continued. Another excellent box that I pulled from your textbook, communication with the family. These are very good pointers, questions that you can use to help practice reflective listening so you can help the family process the dying experience. Go ahead and let you guys read that at your own leisure. But yeah, those are essentially awesome examples of the type of questions that you want to ask the family during the dying experience process. Postmortem care and medical examiner cases. If you ever work in an ICU or in the ER, you may unfortunately have to deal with a lot of medical examiner cases. Anyhow, part of the process entails prepping the body for funeral or funeral home disposition. Make sure to always be respectful. Keep in mind that family, religious, cultural traditions. Regulations vary by state and local jurisdictions. Whichever hospital you end up working, they should train you on, rules and regulations, and every hospital should have the protocols in that regard. If your patient is gonna have an autopsy, main point here is do not remove any kind of tubes, for example, like an intubation tube, IVs, central lines. Don't remove any Foley catheters. The body will proceed to the medical examiner, and they're the ones who would, take care of the extraction of any tubes or catheters. Usually, if they're not going to have an autopsy, you could perhaps remove those tubes. The main thing here is to clean the body as much as possible. Involve other staff in this ritual. It's definitely not a one-person job. I mean, I've have dealt with taking bodies to the morgue, like I said, with my experience in the ER and that's in the trauma bay. So yeah, this is definitely not a one-person job. So yeah, it's a ritual, and like during the whole process, you gotta be respectful, and it's very much a team effort. Domain number 8 is in regards to legal and ethical issues regarding end of life. We are guided by the principles of beneficence, non-maleficence, and justice. Keep in mind that you need to make sure to assess for patient decisional capacity. Does the patient have ability to understand nature and consequences of proposed treatment? Does the patient have the ability to rationally evaluate burdens, benefits, and risk of treatment? Does the patient have the ability to communicate a decision? These are the type of questions you want to ask yourself, if determining if they have capacity to, make certain decisions. Determining and honoring advanced directives. For example, CPR, artificial ventilation, dialysis, artificial hydration, nutrition, antibiotics, and vasopressors. We got to make sure to honor whatever the patient wishes, in regard to advanced directives. Continuing on the topic of domain 8, legal and ethical issues regarding end of life. I pulled this box 5.6 from your textbook. I think it's a very good descriptors of what a well-managed death entails. Appropriate pain and symptom management. Don't want to prolong the dying process. Want to make sure that the patient has feeling a sense of control. Spiritual or emotional sense of completion, not being alone, for example. I feel that not having a well-managed death leads to kind of segues into our next topic, moral distress and end of life. I personally have had moral distress in regards to end of life topics. A lot of times as nurses, or doctors, or social workers, or etc., we ask ourselves. I've asked myself this: are we doing the right thing? Is this in the patient's best interest? Is this ethical? Does this jive with your code of ethics? We have an ethical obligation to advocate for the patient at all times. I've had disagreements with doctors, that is, even with other nurses, in terms of what is best. And these disagreements will arise not only with doctors or other coworkers, but with patients, family members, and other healthcare team members. There is a historically traditional power structure, chain of command. Some nurses feel, I felt in my history as a nurse, ignored, disrespected as professionals. I do feel that there is a historical chain of command, where it's what the doctor orders. Nurses expected to implement decisions they do not agree with. Unfortunately, this leads to moral distresses as a nurse. Unfortunately, there's sequelae to moral distress. Foreign disengagement from patient. This can lead to poor patient care. Anger, frustration, feeling powerless, dissatisfaction, emotional and physical exhaustion. This leads to burnout. I've been there. I mean, I'm sure a lot of nurses who've been nurses long enough have had burnout. Loss of job role fulfillment, turnover within the profession. This can lead to that. Solutions for moral distress involve healthcare organizations to develop, implement processes to solve moral distress. In other words, involve your the institution that you work in. Involve the ethics committee. Encourage dialogue. Take a break, from nursing home. End of life nursing self-care strategies individually. You can talk with trusted friends, RN colleagues, journaling, exercise. That's one way that I personally de-stress. Exercise. I like to run. That's my my way of like exercising my demons. Yoga, meditation, praying. Take a long hike. Literally, in my personal experience, I think when I was like 5 or 6 years a nurse, I took a long hike. I was kind of burned out from nursing from this, and I decided to hike for 5 months, and I that reset me a lot. I came back refreshed. So yeah, there's ways that you can individually take care of yourself. So collectively, strategies to help nursing self-care. Post-mortem care as a team, moment of silence after a death of a patient. When I worked at ER, sometimes, when we would code patients, a lot of times codes don't, patient ends up dying. We got to make sure we would have a 30-second minute moment of silence, in respect of the patient. So we need to make sure to, do those kind of things, not just be like, oh, patient died, we're done. Like, no, we need to there's a bereavement process, family bereavement card, debriefing with crisis intervention to staff. I've been involved in many debriefings after a serious code or a major trauma in the ER. Even in med-surg, the floor that I used to work in, we had no deaths until all of a sudden, we had a week where three of our patients died. It's like all of us were kind of like, what's going on? So we had a little, crisis intervention that involved the chaplain, social worker. There's counseling services. So there's many ways that you as a nurse got to make sure to do self-care. All right. I did reference your chapter 5 textbook quite a bit, and that is my lecture presentation on end of life. Thank you very much.